Hey Ubba-Bubba, welcome to JuanMD. My name is Juan, and today we are going to talk about diverticulosis. Though the colon is a relatively long organ, this is going to be a relatively short video. So without further ado, let's cut the and get right to it. Diverticulosis is a focal outpouching of mucosa and submucosa through the muscular layer of the colon due to increased intraluminal pressure, and this typically happens in the sigmoid colon. This is prevalent in patients with increased age, and risk factors include inactivity, obesity, high-fat diet, and low fiber intake. Most of the time, diverticulosis is uncomplicated, either asymptomatic or presenting with a vague lower left abdominal pain. In other cases, this can present with rectal bleeding, either painless or severe, persistent, and recurrent. In all cases, you would want to do a CT scan, and sometimes you'd want to do oral and IV contrast. Abdominal x-rays in these cases are non-diagnostic, and in other cases, you might want to do a barium enema and a colonoscopy. If a patient has painless rectal bleeding and a colonoscopy cannot localize the bleed, you might want to do a tagged red blood cell scan. If lifestyle diet and fiber intake improves the patient's condition, then nothing further is indicated after discharge. However, if the patient does present with rectal bleeding and this is either severe, persistent, or recurrent, you would want to do a segmental colectomy. The more popular complication of diverticulosis is diverticulitis. This happens when there is fecal blockage of the diverticulosis, resulting in inflammation and erosion of the bowel mucosa. And whenever there's inflammation, there can be problems. There are 4 different complications of diverticulitis. The first one is bowel obstruction due to a response to the inflammation, resulting in chronic bowel thickening. Another complication would be colonic perforation. That can result in peritonitis because of leakage of bowel content into the, peritoneum. Other complications can include fistula formation between the colon and the bladder, called a colovesical fistula, or an abscess formation. In these cases, you would again want to do a CT, but this time with oral and IV contrast. Though an abdominal x-ray is non-diagnostic in diverticulosis, in these cases of complication, you would want to use these to rule out other causes. In the presence of diverticulitis, barium enema and colonoscopy are contraindicated. What's your initial management for patients with these complications? First, you want to do IV fluids, IV antibiotics, nothing per aurum, and bowel rest. Colovesical fistulas, if they do close spontaneously, you would want to give them antibiotics for 10 to 14 days. However, if they don't close spontaneously, you would want to do surgical management. For abscess formation, you would want to do percutaneous drainage, and for large abscesses, you would want to do larger surgeries. For bowel obstruction and colonic perforation, surgery is indicated. For all instances of diverticulitis, you would still give antibiotics after discharge to prevent recurrence. Management is important to prevent any further sequelae, such as sepsis, from taking place. And that, my friends, is diverticulosis in a nutshell. What do you guys think? I hope that video was helpful, and if you guys liked it or not liked it, please click on that like button down below. Also, hit the bell and hit subscribe so that you can stay tuned for future videos. As always, guys, this has been Juan. Remember, first, eat a lot of fiber in your diet, and second, always live life to the fullest, because you only have one life to live. So without further ado, let's cut the poop and get right to it.